which will be on pharmacological management in first episode psychosis, why it is important to approach it differently, and it will be delivered by Dr. Urvaksh Mehta. I would like to invite Professor Shubmohan Singh, Professor Sydney Moirington, and Dr. Akhilesh Sharma to chair the session. Dr. Shubmohan Singh is professor in our department and has numerous publications and awards to his credit. Professor Sydney is a professor of psychiatry in NIMHANS, Bangalore, so is credited with a number of papers and awards. Dr. Akhilesh is associate professor in our department and holds a number of laurels and publications to his name. I would request the chairpersons to kindly introduce the speaker and moderate the session.
Hello. Yeah. It's my pleasure to introduce Dr. Urvaksh. He's a good friend of mine. He's currently an additional professor of psychiatry in NIMHANS, and he's done a lot of work in social cognition. I followed his work, and also in brain stimulation. One of his areas of interest is also neurobiology of schizophrenia. He has numerous publications and he's very well cited. He's got a lot of awards and fellowships to his credit. And today he's going to be talking about pharmacological management, or how it is different from the routine management of schizophrenia, especially with first episode psychosis. So thank you for being here, and take it away.
Initiate the drug, how long do I continue, maintain, if there is no response, how do I switch, stop, etc. So that's all part of the larger treatment process. So diving right in to understand what are the pharmacological practices which are different as compared to chronic schizophrenia, for example. Monotherapy with a first or second generation antipsychotic drug is the first and foremost recommendation. So 2 antipsychotics are not recommended. Treat with a single antipsychotic drug. The lowest effective dose has to be prescribed, and there is a lot of evidence garnered over the period of years based on clinical studies on first episode that you require perhaps a smaller dose, 60 or 70% of the full dose, to treat more multi-episode or chronic schizophrenia. We also start lower. There are more possibilities of side effects. We need to be watchful of side effects, especially metabolic side effects, because they are not apparent initially, and over the next few months, by 6 months, you could see a very different person in front of you. Also because you are starting treatment early during the course of their age, there is more susceptibility for metabolic as well as extrapyramidal side effects. Treating with more than one class of psychotropic drugs is also discouraged. So there have been studies of prescripting practices, and they find that first episode psychosis receives not just an antipsychotic but also an antidepressant, whereas there is no clear indication for an antidepressant there. So yes, so these are the sort of broad best prescription practices in first episode psychosis that can be different from multi-episode. Finer details also exist. First generation antipsychotic choice is actually discouraged by some treatment guidelines, but not all. Most say that you start with a newer or a second generation antipsychotic. The Port, Ranzip and the Harvard guidelines recommend that olanzapine not be used for first episode treatment. Now, initially the first set of guidelines didn't make that statement, but over time people realized the possibilities of metabolic syndromes and diabetes, hypertension, the whole lot of side effects with olanzapine, weight gain, and they have recommended it to be used as a second line. Now, we had a discussion on long-acting injections. This is a very interesting area. Long-acting depot preparations can be used in cases of patient preference during first episode, or when there is poor compliance. There is a growing call for its increase in use among first episode psychosis also. Dr. Tara mentioned Dr. Henry Nasrallah and many others swear by this, and they say that it has improved outcomes by leaps and bounds. It's perhaps because it ensures compliance. But we don't use that very often. I don't know the practice prevailing in this part of the country, but back in Bangalore in NIMHANS, and also Dr. Tara mentioned that somehow doesn't translate to using first generations long-acting antipsychotics during first episode psychosis. So definitely this needs more support from real-world implementation studies. Costs are a major restricting factor, and even among long-acting antipsychotics, second generations are thought to be better than first generations. That is also there from recent meta-analysis. The most common duration of an initial treatment of an antipsychotic medication for first episode psychosis is generally considered as 4 weeks. People say 6 weeks or 8 weeks. A good chunk of them respond even earlier, 2 weeks. However, there is a gap. We know that there are some people who would respond later, or who would respond slow, and there is limited guidance on that. So if there is very minimal improvement, do you continue longer? Sometimes if you rate them on a rating scale, you would see not much of improvement, but the family says that yes, he or she is muttering or smiling, but at least she has started doing some work, she is listening, she is taking care of herself. So there is limited guidance on slow responders. Quetiapine is not recommended for as first line by some guidelines, for example the Harvard guideline, because of poor efficacy data regarding relapse prevention or maintenance of remission. Also, another caveat is that not all antipsychotics have been evaluated in first episode schizophrenia. There are RCTs which examine RCTs in schizophrenia, but first episode psychosis data, for example, among first generation, only haloperidol has been used in an RCT to understand, but treatment recommendations give a blanket statement that any first generation can be used. Somebody asked about the phases of treatment, how long do we treat? The very first guideline for the management of psychotic disorders, particularly schizophrenia, the expert consensus guideline defined these 3 stages of treatment. The acute phase, which can last from 4 to 8 weeks, you give the tolerable dose, effective tolerable dose, and then monitor for 4 to 8 weeks. 6 weeks is generally taken as a good measure of treatment response, and whatever dose they respond to, you continue that for 6 months at continuation, during the continuation phase, and during the maintenance phase, especially in first episode psychosis, you can gradually taper during the maintenance phase at about 20% every 6 months. So that tapering process takes about 2 to 3 years. So the overall treatment for a first episode who is likely to be a responder will go on for a period of 2 to 3 years, and then once you taper and stop, you can wait and watch. If there is a second episode, you repeat the same process again, with the maintenance phase being even slower, 10% every 6 months. And if there is more episodes, then perhaps you need to give indefinite treatment. So this is a general framework which is, since that first guideline, being used in all subsequent guidelines with some tweaks. There are some changes made. Resistance is, of course, we know that it's defined as where 2 or more failed trials are there. Now, what do we base our choice on? This many of us know, we practice. We need to know the menu. We need to know the various forms of antipsychotics available, the routes of administration, their pharmacodynamics and pharmacokinetics, and the process. How do I choose? You choose based on effectiveness. For a long time, it was said that all antipsychotics are similarly effective. Clozapine is more effective than all the other antipsychotics. Over time now, with more refined analysis, we know that perhaps after clozapine there are other antipsychotics which have larger effect sizes, like amisulpride, olanzapine, risperidone. They have better effect sizes as compared to, say, aripiprazole or other first generation antipsychotics. So you also look at side effects and tolerability. You look at measures like effect sizes and number needed to treat, number needed to harm. You look at pragmatics. You look at your experience, expert suggestions, reliability estimates. You also look at your clinical judgment, which is driven by sixth sense. Collaboration, someone talked about informed shared decision making with the patient and caregivers. It is a common practice to do that in the West. It is a growing culture in India. It has not yet caught up completely. Ideally, it is likely to be helpful. This is the summary data. You see the network graph on the left side, where you see it is a small graph, but you see the big red blocks are the ones, red balls are the ones where the drug which has the most number of studies. So you can see, apart of course from placebo, you see risperidone, olanzapine, haloperidol are the most common. No pointer, thanks. Yeah, risperidone, olanzapine and haloperidol are the most commonly studied. So we have a large evidence. And this graph on the right is from the latest meta-analysis in 2019, where you see clozapine is the highest effect size, followed by amisulpride, zotapine, olanzapine, risperidone are almost the same. And then you have the others. So this gives a good estimate for us to understand the effect sizes. So that is for acute phase. And this is for longer term treatment. We find good evidence for antipsychotics at anything more than 6 months to prevent relapse. So this is basically evidence that antipsychotics are useful and need to be used in first episode. As Dr. Tara mentioned, response initially is fairly good, about 60 to 80% based on different levels of cutoffs that we use show a treatment response. That's a good number, and the response is seen in the first year, second year, it is well maintained. By 5 years of follow-up, however, for various reasons mentioned below, a majority of them experience a relapse. 82%. 78% who have recovered from their first relapse then have a second relapse, and 86 of who have recovered from their second relapse have a third relapse. So there is a concerning deterioration there. So this is typically in the case of first episode psychosis, which go on and develop schizophrenia. Poor medication adherence is a significant challenge, which is discussed and reported in multiple first episode schizophrenia trials. Higher risk of treatment dropout is also there. And what researchers have found is that this dropouts and poor adherence is especially present if individuals are not supported with individual engagement or some kind of psychosocial therapy. So if you just prescribe the medication, there will be good response initially, but over time there can be a decline. So moving from that idea, there have been now strategies called coordinated specialty care programs, CSCs. So this is a favorite program of the NIMH in the US. This is especially for first episode psychosis, where you use a team-based multi-component recovery-oriented intervention. The most recent example is the Navigate program from the RAISE trials. RAISE is recovery after initial schizophrenia episode. This typically talks about a shared decision-making approach, pharmacological treatment. Non-pharmacological treatment includes patient and family education, resilience training, which basically includes setting of goals, giving them some existential meaning, taking steps to accomplish the goals, supported employment and education, which comes as a spin-off from the resilience training. So this is, there are effectiveness trials. The most recent one published for this Navigate program recruited 400 patients across 17 sites in the US, and found that as compared to a control intervention in an RCT, the outcomes in terms of better patient engagement, occupational outcomes, quality of life, all the outcomes were better when you did this kind of a CSC approach, comprehensive treatment. However, there are caveats here. Each site had all these 17 sites, each of these sites had a team of at least 5 mental health professionals, a psychiatrist, a psychiatric nurse, 2 clinical psychologists, employment and educational specialists. This roughly translates to 5 professionals catering to 30 patients over 2 years at each site. Now, is this possible to translate to? This is a high resource setting in the US. We can only dream of doing that in India. But the outcomes are there to see. 2-year outcomes are sustained as long as engaged in specialized care. So as long as these 5 people are treating 30 patients, they have good outcomes. This is a similar approach used in Europe, and this is again in the US at Yale. They show good outcomes. Now, when the treatment has been stopped, this coordinated specialty care was stopped, longer term follow-ups, the durability of effects after stopping was poor. So they deteriorate again. So the same Danish Opus study, they stopped the intervention at 2 years and then followed them up at 5 years, and found that there was no difference between who received CSC at baseline and at follow-up. The Dutch treatment intervention study also showed a similar picture. This was even a longer follow-up. So, what are we to do now? Now, you can see that there is a deteriorating trend, and coordinated, comprehensive treatment is challenging, but it lasts as long as the treatment lasts. So now this actually gives me an opportunity to look at the right side brain discussion that I spoke about. Now let us step back a little from first episode psychosis pharmacotherapy and look at how first episode psychosis can be an opportunity to advance science, and this is what I propose in terms of prognosis research. We know that schizophrenia is severely disabling disorder despite its low point prevalence. 3 to 4 per thousand is the point prevalence, yet it rates among the top 10 disabling conditions. Why is that so? It is understood that most of the disability in treatment in schizophrenia can be attributable to poor treatment response, symptom persistence, or treatment resistance, any level of treatment resistance. Treatment resistance also accounts for the most healthcare utilization costs, caregiver burden, physical morbidity and mortality, suicidal risks. The contact coverage for schizophrenia, as Isha mentioned, is around 40 to 50%, which is pretty low as compared to even China or the developing countries. Schizophrenia is easily recognizable, yet only 40 to 50% get access to seeking treatment. So now with all of this, a CSC model not being practical here, improving the treatment outcomes of resistant schizophrenia should be the top priority of schizophrenia research, according to patients and caregivers. So this is a stakeholder study. Patients and caregivers were asked, what if you were given money to invest in schizophrenia research, where will you invest? And they rightly pointed out that improving outcomes of resistant schizophrenia is what we would like to see the money go in. So that brings us to the question which Professor Kulhara asked earlier. So at baseline, can we identify who is it that is going to develop treatment resistance, and can we do a more intensive treatment for them? There are many studies from community settings in the whole of the country which show that predominant pharmacotherapy with some form of brief psychosocial intervention is sufficient for a lot of patients. Treatment resistance accounts for about a third of schizophrenia. So in those, you need that CSC kind of an approach. Now, if you don't know who those third are, you can't start giving CSC to all. So that is also a challenge. So is there utilization of this prognosis research paradigm in identifying potential non-responders early in the course of treatment and then giving that kind of intense psychosocial treatment to them? Now this is called the resistance prevention paradigm. There are different models of resistant schizophrenia. One is that it is perhaps on the continuum of risk, more genetic load, and hence they develop more risk for developing schizophrenia, so they have severe schizophrenia. The counterpoint is that it is a different etiological type. It has a different genetic overload as compared to the general schizophrenia, which is seen. We saw that some have persistent negative symptoms, some have florid positive symptoms. So there is some merit in, and of course there is a combinatorial type where you find a complex interplay of genetic risks and cascading effects of relapses. Now relapses can be difficult because they have different kinds of so more the relapses you have, it has a neurotoxic outcome on the brain, which then predisposes you to develop more treatment resistance. There is also sociotoxicity and psychotoxicity as put by these authors, that you get more stigmatized, you have more cognitive biases if you have relapses, and it's a complex interplay of how the person's genes, environment interact in determining poor outcomes. So the implications for first episode schizophrenia to identify treatment resistant schizophrenia is to be considered. So can we do some kind of assessments which at baseline will help us identify treatment resistant schizophrenia so that you can adapt that more comprehensive and effective model in potential treatment responders early on. So when I talk about a prognosis research framework, this is what the field is generally talking about. This is of course not in psychiatry. This is coming mainly from oncological studies, where the first job to be done is you describe the natural history of the disorder, the course, the outcome, and this is very well done. We have a lot of studies starting from the IPSS, the SOFA course, the DOSMED, and several other studies which cover the Indian population also. So we have described the course and outcomes. The second aspect is look at associations with candidate prognostic factors. This is also started, a lot of work has gone on. I'll talk about what clinical and when we talk about prognostic factors, they can be clinical, which can be assessed during a clinical interview, and they could be biological, which you measure using certain instruments. And then this will tell us not only about developing a prediction model. So you can develop using different statistical techniques, you can develop a prediction model and then use that in deciding a clinical rule that okay, this set of parameters will tell me that this person is likely to go into developing treatment resistance. So why not I allocate my resources more to this person as compared to this other person who perhaps is likely to have a milder outcome. It is easier said than done, but at least we should think of moving in that direction. It will also, as a spin-off, it will also tell us about the etiology of schizophrenia. So perhaps schizophrenias, one of the schizophrenia types is a poorly responding schizophrenia, poorly responding to typical medications that we give or treatment that we give, the dopamine blockers. The same we have applied to first episode psychosis, and here the dictum should be that the at-risk population. Now this is something like akin to primary, secondary, tertiary prevention that we talk about for diagnosing a disorder or reducing disability. Here you have to move the disorder and replace it with treatment resistance. So instead of looking at a risk for developing schizophrenia, you look at the risk of developing treatment resistant schizophrenia, and there the target population would be first episode psychosis. So you subject these first episode psychosis patients to whatever is the most parsimonious way of subjecting them to different clinical and biological assessments. Not all assessments are everywhere available, but a range of clinical markers, range of biological markers should be whatever best available should be utilized, and we should build prediction models, examine their clinical utility. There should be internal validation, replication in other samples, and then try to implement that clinical decision making, and then learn from that model, from real world settings, and then improve your model. So that becomes an iterative learning process which you then with which you then refine your prediction models. Robbins and Goose are quite famous in terms of talking about validity of psychiatric disorders, and way back in 1970 they came with this idea of categorizing schizophrenia based on various clinical predictors, and they could identify a series of good prognosis predictors and poor prognosis predictors. Since then, there have been a lot of studies which have gone on to understand clinical predictors. The story is a little grim because at short term you have 1 year clinical predictors of treatment response, or or treatment non-response, male gender, early age at onset, prolonged DUP, comorbid substance use. These are quite well replicated. These two are meta-analysis of clinical predictors of treatment response. However, at longer term follow-ups beyond 1 year, except for poor premorbid social functioning, most other clinical predictors are inconsistent, and they don't have any major magnitude effect size in terms of predicting treatment non-response. So this becomes a challenge. This tells us that based on clinical findings alone, it is not easy to predict. So then we need to move to disease biology determined predictors. Now the field is moving fast. We know that over time we have identified several genes associated with schizophrenia with large genetic consortium studies, and from that genetic data people have developed this kind of a scoring system which is called a polygenic risk score. It is basically you weigh each polymorphism and then get a sum of that. So if my risk of a particular polymorphism is X, I multiply that risk by the presence of that polymorphism and then add the number of polymorphisms which are there. So that gives a risk for schizophrenia. So this is based on the risk for developing schizophrenia. Unfortunately, this really big study by Landy and colleagues, which was published recently in Nature Medicine, found that for all treatment outcomes that were investigated, the polygenic risk score developed from the schizophrenia risk data did not improve performance of predictive models. So it's a downside. However, a year later, so what this paper recommended was not to look at schizophrenia polygenic risk. Instead, you look at risk for treatment-resistant schizophrenia. So those people who have treatment-resistant schizophrenia versus those who have good response schizophrenia, they looked at the polygenic risk scores of that, and there they find that there is an association between the TRS polygenic risk score and history of taking clozapine. So there is some merit in using polygenic risk score. Similarly, in imaging studies are a little better. The striatal dysfunction, this is again a paper published by a Chinese group which has centers from China, Australia and Europe, a multi-center prediction trial which looked at striatal dysfunction using resting state functional brain imaging, and they found that it is a reliable, well replicated biomarker of treatment response. We performed a systematic review and found that striatal functional connectivity and default mode functional connectivity had 81% sensitivity and 76% specificity in predicting treatment resistance. So these are encouraging signs. I would like to share my PhD work, which was on a similar topic, genetic brain connectivity and cognitive predictors of treatment response. So we had a total of 58 schizophrenia patients. 44 were characterized as responders, 14 were characterized as non-responders, and we used a functional connectivity measure, which is the connections between the default mode and the task mode, and the connections between default and task mode were used to predict treatment response. So what we found was clinical predictors alone again had a null effect. None of the clinical predictors had a significant outcome, and here the outcome was treatment response at 6 weeks of antipsychotic risperidone treatment. fMRI alone had a small effect. Where we combined fMRI and clinical, there was a better effect, and that better effect was characterized by an area under the curve of 90%, sensitivity of 95%, specificity of 71%. So that is what you can see here in this graph. The red plot is the ROC curve for fMRI alone, and the black plot is the ROC curve for fMRI and clinical. So there is some meaning in combining imaging metrics with clinical data in determining who is likely to have a poor response. So that now brings us to the question, are we headed towards personalized medicine, stratified medicine? There are a lot of lessons to take home from oncology, various treatments which are disease biology determined, but is it relevant to psychiatry? Perhaps not now, but there is a chance that soon we could see that. Now this is a plot of the number of cases recruited and the number of genes identified for schizophrenia. So this starts from almost less than 10 genes in 2009 to almost 250 genes in 2022. This is when it was recently published. So just in the last 10 years, we have seen a spike in the genetic understanding of schizophrenia. More than 250 genetic loci have been identified. Majority are common alleles. There are rare copy number variants, coding variants. Majority are expressed in the brain, and although they at best explain around 7.5% of the variance in heritability, they give us something to work with. So when they looked at RNA expression of the genes in different tissues, they find that it is all these 250 genes express mostly in the brain, different regions of the brain, which is reassuring. It at least tells us that the genes responsible for schizophrenia are not expressed in the pancreas or the adrenal glands. It is expressed in the brain. Even within the brain, where is it expressed in specific cells, that also is known. So they are most commonly expressed in the hippocampus, the somatosensory cortices, and cortical interneurons. So this is basically RNA inside the cell of that particular gene, those 250 genes which were implicated in schizophrenia. And what do these genes do in the brain and in the specific neurons? They have a role in immune regulation. They also have a role in synaptogenesis and synaptic function. So this is a paper which describes the particular genes associated with schizophrenia relate to expressing excessive complement C4, which results in excessive pruning and lesser number of synapses in schizophrenia. And the most recent PGC study also shows that most of these genes, if you map their functions, they are related to synaptic function. So this, as I said, personalized medicine comes along with a better understanding of diagnostic and nosological validity. So prognosis approach, which will help us identify who is a good responder or a non-responder, will also give us a fertile field to understand the diagnosis or diagnostic validity. Now, Bloiler had long time back said that he never coined the term schizophrenia. He's in fact said schizophrenias. And now we can see that from the genetic data that and the imaging data that schizophrenias can manifest as connectopathies, synaptopathies, immunopathies, channelopathies. Which of these is treatment-resistant schizophrenia? Time will tell. But we are still heading in some direction. Now, combining the left and right brain approaches, there are important initiatives, the EPINET, the Early Psychosis Intervention Network, and the PHOENIX. These are two early psychosis data collection portals. So these are almost freely available, uniform, homogenized assessments that need to be done. EPINET is predominantly for clinicians, and PHOENIX is for research purpose. So these give standard tools which anyone interested in first episode psychosis research can use these tools to ensure that your data collection is homogeneous with what people across the world are collecting. So this is one step it's a good step. It is a step in the right direction to ensure uniform data collection and then decide what biological predictors of treatment response or non-response are. There are caveats. There are ethical issues when we talk about prognostic research. Do I want to know when I have schizophrenia, do I want to know that I am likely to develop treatment resistant schizophrenia? Just as much as if I am in a prodrome, do I want to know that I am going to develop schizophrenia? It is perhaps less stigmatizing here because it is more to do with functional recovery and intensive treatment. Do I want others to know that I will probably have treatment resistant schizophrenia? How will it impact my insurance policy? How will it impact my work? How will they treat me after knowing that? Can my doctors do anything to prevent me from going to develop TRS? So what if I predict that I'll develop treatment resistant schizophrenia? Is there something that can be done? We don't know yet, but at least we know whom to target. And once we know that, then we can develop interventions, perhaps more apart from the coordinated psychosocial supports, perhaps brain stimulation, perhaps non-dopaminergic antipsychotics, glutamatergic drugs, hormonal treatment. So it opens up a broad perspective of trying out different modalities of treatment in a systematic manner in those whom we can use data to inform. Now there is this whole concept of predictive myopia. I would like to predict, but what I have a short-term sight in mind. What are the long-term consequences of predicting someone's medical condition? Despite all these caveats, it is still perhaps important that resistance prevention is pursued. It is something which is not spoken about. It is generally primary prevention which is spoken about. It is a good strategy to serve first episode psychosis better, as well as move the field forward. So with this, I will end and I'll be happy to take questions. Thank you.
Thank you, Dr. Urvaksh. It was a very wonderful presentation, giving a new insight of where actually we should be looking, probably even change the nosology and take the step forward. the session is open to take the questions. Before that, a small disclaimer. I am yet to be a professor. It's a few years away. I'm still an additional professor. Thank you very much.